Okay. Good afternoon to everyone. I will present you this study titled The Impact of Disruption in Antigen Processing and Presentation Machinery on Sarcoma. This study is part of a larger project founded by Ministry of Health that is focusing on sarcoma and microenvironment modeling. And by the end of this talk, I hope you will be convinced that if we want to study the microenvironment and we want to do some oncoimmunology for our sarcoma patient, APM is something that we might consider into the scenario. So you all know this story that led to a Nobel Prize, picking melanoma as an example. With the advent of immune checkpoint inhibitors, we had an increase in progression-free survival for metastatic patients that boosted 6 times. How is that? So clinically, what we see is that patients that respond from the very beginning and respond for a while. Histologically, what we see is that outside the tumor, we find CD8 lymphocytes that after treatment with immune checkpoint inhibitors enter the tumor, whereas patients that do not respond from the very beginning, and histologically, we do not find CD8. And so we have these two conditions, the first one in which immune checkpoint inhibitors basically allow CD8 to come in and kill tumor cells, and the other condition in which cytotoxic T lymphocytes are not there. So the question is why they are not there, and I want you to suspend this question for a second, and let's come back to our favorite topic, so sarcoma. Immune checkpoint inhibitor experience in sarcoma has not been very satisfying, to be polite, and basically just few histotypes respond to immune checkpoint inhibitors, and overall the response rate is not satisfactory. And so coming back to the why, we focus all our effort, or most of our effort, on this killing process. Okay, so we focus on PDL, PD1, CTLA4, and so on and so forth molecules, and we ignore, more often than not, but before killing, we need CD8 to meet the tumor cells or any other cell, recognize it, and then can kill the cells. So how cytotoxic T cells recognize a self or non-self? So we have that all the proteins are ubiquitinated and clived by the proteasomes. The peptides move to the endoplasmic reticulum via this transporter associated with antigen processing protein that is called TAP, that has a couple of subunits, and then the peptides are loaded on this MHC class 1 that has 2 subtypes. These meet the T cell receptor on T cells, and this complex altogether makes the recognition of the cell. So we decided to characterize subunits of all the components we described so far in the most frequent sarcoma histotypes. We pulled up 126 cases of sarcoma, among them UPS, myxofibrosarcoma, the differentiated liposarcoma, gastrointestinal stromal tumor, myxoid liposarcoma, and soft tissue leiomyosarcoma, chondrosarcoma, and for institutional reason, we also included chordomas. And moreover, we tried to account for the tumor heterogeneity. As you all know, sarcoma can be very large, okay? So they do not fit on one slide, and if you have different part of the tumor that have different features, so we try to picture this complexity, designing a TM8 that took both high-grade areas, low-grade areas when they were present, areas with a high inflammatory infiltrate, so, defined as under H&E, you find lymphocytes, so we sample them, and then also the edge of the tumor, 1 millimeter before the edge, that is tumor periphery, and 1 millimeter outside, that's tumor border. Okay, so what did we find? All the investigated sarcoma type had some defects in APM. Just to pick a couple of examples of the study, the differentiated liposarcoma, for example, had defects in alpha subunit of the major histocompatibility complex, in 1 patient out of 4. So we expect that 1 patient out of 4 will have this kind of defect in alpha subunit, in DD-LPS. And similarly, leiomyosarcoma for proteasome subunit LMP10, 1/3 of the patient will have a deficiency of this protein. Flipping the coin, all the APM molecules that we studied were altered in some, at least in one sarcoma histotype. Okay. Next, the spatial point. So what we saw is that areas that had lymphocytes tend to have preserved APM, antigen processing machinery, whereas area with the high grade tend to lose it. So again, this on second thought is it's very intuitive. If you see lymphocytes, APM needs to be present, and we also statistically confirmed this. That was not just eyeballing, but we saw that there was a real difference between this area for specific histotypes and specific proteins. Next. We demonstrated that APM, antigen processing machinery deficiency, is prognostic, both for disease-free survival and overall survival in the differentiated liposarcoma and leiomyosarcoma. And so basically, we in the study has been published yesterday in cancer immunology and immunotherapy, and if you Google APM sarcoma, you can download the preview, so the preprint. And so in this study that is much more long and rich in a sense, we demonstrated that APM is deficient in sarcoma, and the deficiency is very heterogeneous. It changes among the different histotypes. It changes within the tumor type. So inside, and this we are used to that in sarcoma, that some areas of the tumor have a completely different morphology than other areas. We also show the prognostic value of APM loss, that something that has been shown also in many other cancer types where APM loss, antigen-presenting machinery is altered. And I hope that by now you are convinced that in the future, if we want to personalize an oncoimmunological treatment, even in trials, antigen-presenting machinery is something that we need to take into account. Thank you.